Okay, wonderful. Well, thank you again to all who've joined us today for the OCRA International Conference and our Ask the Experts series. I am delighted to be your host and moderator today. My name is Amanda Fader. I am a professor of GYN oncology at Johns Hopkins, and I'm a rare tumor specialist and immediate past president of the Society of Gynecologic Oncology. And I'm so delighted to be, thank you for the honor of doing this to the OCRA and Liza, Tracy, and so many that included us in this wonderful forum to be able to dialogue with survivors all over the world. And I'm really deeply honored to be joined by some of the most exciting and talented GYN oncologists and rising stars in ovarian cancer and gynecologic cancer research in the field today. And I'm going to have each of them introduce themselves. I'm going to start with Dr. Armbruster.
Hi, everyone. So excited to be here. I'm Shannon Armbruster. I'm an associate professor at Virginia Tech Curling Clinic. My research ever since residency, so that's now 14 years, has all focused on improving the survivorship of GYN cancers. And that's from physical health to mental health to quality of life and including their caregivers as well. So I'm so excited to be here.
Thank you, Dr. Armbruster, as are we. Dr. Marjon.
Hi, I also am very excited. Wow, these just keep setting things up for me. Okay. I'm really excited to be here and I appreciate the opportunity to speak to you all and answer questions. I work at the University of Colorado and I'm here as a physician scientist. And that means that I spend 20% of my time actively caring for patients and having clinic. And like right now I'm on call. And then I spend 80% of my time doing research in the lab and running a lab group. I am currently an OCRA scholar, and so I received one of their early career investigator awards, which is allowing me to do my research. And my research is specifically in immunotherapy and ovarian cancer and seeing if we can manipulate other parts of the immune system to help activate it against cancer.
Thank you so much, Dr. Marjon. And the OCRA is such a pivotal foundation in funding the future and the current scholars that are really driving change in our field and improving the lives of our patients. So thank you for being here. Dr. Toboni.
Hi, my name is Michael Toboni. Thank you for having me today. I'm an assistant professor at the University of Alabama at Birmingham. My area of research is largely in endometrial cancer and clinical trials, although as GYN oncologists, we care for all patients with ovarian cancer, vulvar cancer, cervical cancer, et cetera. And we do have multiple clinical trials open here involving ovarian cancer. I'm the head or chair of the disease-oriented working group at the O'Neill Cancer Center. And so do have experience with ovarian cancer trials as well. But Dr. Fader has been a great mentor to me, and we are principal investigators of a new endometrial trial coming out called NRG 035.
Thank you, Dr. Toboni. Wonderful to have you. And Dr. Zamorano.
Hi, everyone. I'm thrilled to be here. I'm Abigail Zamorano. I'm assistant professor of GYN oncology at the University of Texas MD Anderson Cancer Center in Houston. I am also an OCRA scholar. I'm the health equity scholar this year for some research looking at addressing the social determinant of health needs of specifically our gynecologic cancer caregivers. And so we're working on creating a method by which we can navigate caregivers specifically to any specific like social determinant of health needs that they might have while they're helping their patient through their cancer journey. I also focus a lot of my time on cancer prevention, specifically cervical cancer prevention, and I have some state funding to address social determinants of health and increasing access to cervical cancer prevention and dysplasia diagnosis and management in Texas.
That's fantastic. And another way, there's so many different ways, again, the OCRA contributes to scholarship and supporting the most talented people in the field. And Dr. Zamorano's work is really critical to closing some of those important gaps in prevention and treatment. So speaking of prevention and diagnosis, we're going to kick this off with a variety of topics. You are all so kind to send us hundreds of questions in advance, and I know we welcome your live questions as well. And we're going to do our very best in 2 hours to get as many through them as we can, but please forgive us in advance that it will be impossible to hit all questions, but we'll try to group them thematically so that we can answer as many of the pivotal questions as possible. Please also know that we will not be able to entertain questions regarding personal treatment recommendations, as we are not caregivers to the many wonderful individuals who are on this call, but we can give general answers about questions regarding treatment and side effects and survivorship care and genetics and testing and any questions you have for us, we're here for you. So let's go ahead and get started with genetics, which I think is a really important topic, and we've received a lot of questions about this. And one of them was about, what percentage of ovarian and endometrial cancers are genetic? When should someone be tested genetically? And then a follow-up question that a patient had was, when should their family members be considered for testing? And I don't know if anyone wants to tackle that in particular.
Sure. I mean, I'll start. I think that it's important for anyone with an epithelial ovarian cancer to be personally tested. So germline testing. We also obtain somatic testing, which is genetic changes that are localized to the tumor itself. And that really opens up for different types of therapeutics. But germline testing for all epithelial ovarian cancers, including mucinous cancers, which was a recent change, should happen with each individual person. And then I don't know if anyone else has anything to add.
What kind of genes are we looking for that we test for in these cancers?
Definitely BRCA, PALB2. BRCA, I think, make up about 25% of epithelial ovarian cancers. And then there's some other genes down the line that we continue to look for as well.
Yeah, absolutely. We do now multi-gene testing for our patients that we are concerned might have a inherited or genetic component to their cancers. And so BRCA is, yes, one of the most common, the BRCA, but there are, I think, over 47 different genes now being tested for ovarian and endometrial cancers. And a lot of questions around when testing, what's the difference between like a genetic test and a tumor test that we might do, like a molecular test on the tumor? Dr. Marjon, do you want to maybe take that one?
Sure. So when you're testing your germline, which was what we were just talking about, that's actually testing whether or not you can pass that down to family members. So I think part of the question was, when should family members get tested? And that's if one of your genes comes up as what we call a pathologic variant, or something that could pass down and increase their risk for cancer. So then they know that they could do screening and preventative next steps. So that's when they should be tested. When we talk about tumor testing, your tumor itself can end up getting mutations that the rest of your body doesn't have. And those are specific to the tumor that developed. The reason we test the tumor is because it can help us decide different treatments. So we have different targeted treatments based on mutations in the tumor. And so we often do tumor testing either right away at diagnosis or at first recurrence to try to make a treatment plan and be prepared for down the road treatment options. And we test it for different genetic mutations. We test it for maybe expression of certain proteins that we can target, and then markers for the immune system. So maybe we can target the immune system as well. Did that answer your question, Dr. Bader?
Yeah, I think that's excellent. And we're getting some questions in the chat as well. And from our prior, our pre-session questions regarding, let's say someone does test positive for BRCA1, for example. There's a two-parter here. When should their children be considered for testing or recommended to go undergo testing? And then what cancers are folks with either BRCA, BRIP, or a lot of these DNA regulatory, tumor suppressor gene mutations at risk for in women and men?
I can speak about just family members. So I think there's something called cascade testing, which is where the initial patient who usually has the cancer diagnosis is the one who is identified to have the gene mutation. Then they are a huge fund of knowledge for the rest of their family members, because they can then be the one to talk to the rest of their family members about testing or not. The timing of testing is a very personal decision. And so I recommend to my patients, family members to meet with a genetic counselor to talk about that. There is a thought that, if you are going to have genetic testing and you don't have a cancer diagnosis, having a pathogenic mutation can potentially impact your ability to get life insurance. So we do recommend that you kind of have things in place before you undergo that testing. This is more applicable to children, for example, or like your kids who would undergo testing. But it won't impact your ability to get medical insurance. And so that isn't a worry. But it is important to share this information with your family members, because the family members that have then not been diagnosed with cancer can potentially take preventative steps to keep them from hopefully ever getting a cancer.
Absolutely. These are great answers. This is life-saving to have this information. It's empowering for families to know, so that, because in many of these cases, there's prevention opportunities, which we're about to pivot to. I'm just seeing a couple questions in the chat, and wanted to point out Tracy's excellent text that OCRA has a free genetic testing program that is absolutely incredible, and everyone who wants more information about genetic testing should definitely look at that. There's always questions about what I had my testing 10 years ago, 5 years ago, I was only tested for these certain genes. Should I be retested? I think those are really great questions. And I think we would probably all tell you, speak to your provider about your specific mutation profile that you've already had performed. And if you've had multi-gene testing done in the last, 2 to 5 years, it's probably not necessary to undergo repeat testing at this time. But if there are additional genetic tests and mutations that become known to us that are really important or pathogenic in ovarian, uterine, or other cancers that we treat, we will definitely be, share that as research becomes available. Can
I just add
yeah, please,
something very quickly?
Yeah.
For somatic testing, it often comes up, like when we're just testing the tumor, should we retest? And we often use the original tissue because it's easy and you don't need a repeat biopsy. But, different companies test for different things. So if I'm really struggling with good treatment options, I often will get a repeat biopsy and retest. But that's a bit of a personal decision. It doesn't mean every single time you have something, you should get your tumor retested. But often you get one or maybe two of those. Insurance sometimes only covers it once, though. So then you have to be a little thoughtful.
Thank you for that. That's really important. And that's a big difference, again, between the genetic inherited type of genes that we can, possess versus those that are just present in our tumor that we can potentially target with treatments and or other strategies. So, yeah, and sometimes those mutations or proteins, that expression can be gained or lost in subsequent biopsy. So there can be some importance of doing that down the road if a recurrence happens.
I think, sorry, just one other thing is just as new treatments become available, such as like mirvetuximab too, then you might have had testing initially, and then we can go back and specifically test for the different markers that would maybe make you eligible or not for trials. So kind of for more personalized medicine too. So that might be another reason why a provider recommends not maybe doing a full panel, but just testing for one protein in particular.
That is a fabulous point. Thank you so much for that. And there's been a veritable explosion of FDA approvals in an ovarian, in endometrial cancer, and some in cervical cancer as well. This has been, one of the most prolific times in gynecologic cancer research. This has been the decade of trial explosion and new exciting therapies that are allowing us to offer more options to our patients who are hopefully benefiting and living longer from those experiences. Any other comments on molecular genetic testing before we shift gears a little bit? Okay, so let's say there's a question in the chat about BRCA, for example, but we could use any of the genetic mutations. What type of prevention or risk-reducing options are available to patients with BRCA mutations?
I can take this one. So if you are found preemptively to have a BRCA1 or 2 mutation, you can choose to take preventative steps once you've completed, and I'll just talk about GYN cancer, so not breast cancer, but for GYN cancers, you can choose to have your fallopian tubes and ovaries removed. Now, there's some really exciting science going on to look at people who might not be ready to undergo surgical menopause, meaning once we remove your ovaries, that is taking out the natural producer of estrogen and progesterone and other hormones from your body. So some women, individuals might not be ready to undergo surgical menopause. They might be, in their 30s or 40s, but they've completed childbearing. We know that most ovarian cancers are actually not from the ovary, but they're from the fallopian tube. So there's some really exciting science and clinical trials looking at removing just the fallopian tubes and leaving the ovaries inside. And then when the patient is then of a later age and ready to undergo menopause, then removing the ovaries. And these studies, there's two primary ones, the Tuba-Wisp study and the SOROC study. And the options for patients it's entirely up to them. It's not randomized, as in they're not told which surgical procedure to undergo, but it's looking at both their feelings after and like their symptoms after surgery, as well as ultimately their risk of developing cancer. So there's some really exciting kind of movements as to how to best prevent these cancers and how to best minimize some of the other symptoms that we might be causing inadvertently in our attempt to prevent these cancers. Oh, Dr. Peter, you're muted.
I'm on mute. I should know that. It takes tubes, right? It's amazing. This is one of the most amazing modern developments in our understanding of ovarian and fallopian tube cancers. Thank you for that excellent summary of options. What about in low risk women? What's being explored there as well? Can we prevent ovarian cancer? Since most cancers occur in women who don't have these genetic mutations, what can we do there?
I think similarly, there's a big push for us to start taking out fallopian tubes once you're done childbearing. So instead of being, getting an IUD or something else for contraception, an option would be to have your tubes removed. And instead of doing a tubal ligation like we used to, or tying tubes is what we used to call it, now you just remove the whole fallopian tube to prevent that. Also, many institutions are starting to train our general surgeons. So let's say you go in for an appendectomy because you have appendicitis. We're asking general surgeons to be trained to take out fallopian tubes at the same time if patients want it. And I'd say that's not widespread yet, but I think that that's something that's coming down the pipeline. If you go in for something else, that you can get your fallopian tubes removed for prevention at the same time.
Yeah, oh, go ahead, Dr. Toboni.
I was just going to add that there's, to Dr. Marjon's point, there's a recent systematic review which showed 80% reduction in ovarian cancer with self-injectomy. In addition, there's relatively dated but good retrospective evidence to show that if you are on OCPs, you can reduce your risk, which are oral contraceptive pills, birth control pills. You can reduce your risk of ovary cancer as well. And then just to add on to Dr. Zamorano's point, because I'm the uterine cancer guy, but a lot of people will perform a hysterectomy with a BRCA1 mutation because there is evidence to show that there's increased risk of a very aggressive type of uterine cancer with that type of mutation.
Yeah, that's an excellent point. Thank you for adding that, Dr. Toboni. Thank you, Dr. Marjon, for the excellent answer as well. I wanted to add that my colleague here at Johns Hopkins, Dr. Rebecca Stone, and Dr. Carol Longroche up at MSKCC in New York are funded investigators looking at this question of making self-injectomy or removal of the fallopian tubes generalizable for patients at low risk who are undergoing other types of abdominal procedures like Dr. Marjon was talking about. So this is already happening at many centers. It's not yet, I wouldn't say mainstream everywhere, but it's being actively studied. And Dr. Stone and team were able to successfully get the CDC and Medicare and Medicaid to create codes for this so that it wouldn't have to just be for contraception that self-injectomy is being performed. It could be performed for risk reduction of cancer. So there was a couple questions about that in the chat. Am I right for this if I just want my tubes out? Please talk to your physicians about that and what your options are. We're not doing this universally in postmenopausal women at this time just to take out their tubes, but if you're undergoing other procedures that are abdominal or pelvic, or you're premenopausal and also want the tubes removed for permanent contraception, those are options for you at this time. Any other comments about risk reduction procedures?
There's a little bit of discussion in the chat about menopause, which is obviously challenging and very hard, because instead of gradually going through menopause, it is like jumping off a cliff of menopause. So we often recommend estrogen replacement if you don't have a hormone receptor positive breast cancer. And we recommend that at least until the age of 50. And so some people stay on that longer because they just really struggle with menopause. And that's obviously a personal decision with your physician, but it's not just kind of, oh, maybe you could consider it if you have symptoms. Like, it is a strong recommendation if you don't have a hormone receptor positive breast cancer that you're on hormone replacement until the age of 50. And so that's something we often do.
Yeah, I think that's a great question, a great answer, and very important topic to the hundreds of thousands of women that undergo these procedures. It's a big deal to us, and we want you to know that, when performed by expert surgeons or GYN oncologists who really understand, the implications of risk-reducing surgery, your providers will be there for you to help you navigate life after removal of the ovaries. And I am a strong also believer in utilizing hormone replacement therapy when appropriate. Any other comments on
And then
menopause?
if you are hormone receptor positive, there are medications, a new one called Veoza that works very well for hot flashes. It's hard to get approved. They have great coupons. And I'm not a rep for them. It just works very well.
Veoza is increasingly becoming accepted with insurance carriers. We've all had a little trouble with that, I think, because it's a newly approved medication, but it works very well. And any other tips or tricks that others use if you can't get Veoza?
I was just going to say, at least with hormones, it's nice now that there's like combination patches, because if you still have your uterus in place, you'll need that progesterone as well to protect you from developing endometrial cancer. And so patches tend to be a lot easier to use, and we don't forget them as much. And it also decreases your risk of blood clots. So it's kind of cool with all the new advances in medicine that we're, continuing to make strides in women's care.
Agree, Dr. Armbruster. Has anybody used Effexor, magnesium supplementation, or any other techniques for reducing vasomotor symptoms in those who can't get hormone replacement therapy?
I've used Effexor. I think that it tends to work like 50% of the time, I would say. Sometimes gabapentin, but that definitely has side effects that go along with it.
Yeah,
I think the same techniques that our family members have used for decades are not perfect, and especially not for a 35-year-old, but sleeping with your windows open, having a fan on you, having air conditioner on, getting cooling sheets. There's cooling pajamas now. So things like that, although not perfect, can help you get some sleep. So you can sleep through the night.
Yeah, those are great tips. We're seeing some chatter that both Veoza and Effexor has worked for some of our colleagues who are listening in today. So that's good to know. We'll continue to work on more universal coverage of Veoza so that it's not a barrier to our patients. Any other thoughts on menopause? What about sexual health in patients post prevention? What do you recommend there? What can they expect after surgery?
So anytime someone goes through menopause, when you lose that estrogen and progesterone, you are going to have decreased natural lubrication of the vagina. And so a lot of individuals will report vaginal dryness. There are various lubricants to use and other things that are either hormonal or not hormonal. But a lot of sexual health is not just physical symptoms. It's like, very complex individuals. And so talk to your provider because there are resources out there. Sometimes the provider doesn't know that the patient wants to talk about this. And providers don't always bring it up with every single patient, but talk to your provider if you're experiencing, if you have like sexual health concerns, especially, as they relate to vaginal dryness and, postmenopausal symptoms, but also just after a cancer treatment. Like you've gone through something very traumatic with your body and sometimes a patient's kind of view of their body changes after they go through their treatment and they don't really know how to accept themselves or they don't really know how to interpret this like new self that they are. And this applies to individuals of all ages. And so there's no age limit to this, but talk to your provider. There are some really good resources out there. One thing I like to refer my patients to is something called the Rosie app, ROSY. It was developed by an OBGYN in Dallas who basically decided that not enough people were talking about sexual health. And she originally designed it for patients after breast cancer, but then has adapted it to patients who don't have a cancer and then also to patients after a gynecologic cancer. And it has lots of different kind of ways of addressing sexual health. And so I encourage all my patients to look into it. I actually think that there might be some free or promotional option for patients who have a history of cancer. I'm not entirely sure about that, but it's a great option because it really thinks about this in a very complex way to meet the complex nature of this question.
I also just want to put in a plug, like we can manage basic menopause as GYN oncologists, but we certainly, because we're keeping up to date on all of the research in cancer treatment, I certainly can't keep up on all of the changes in sexual health. So if you're in a city or in a place where there are menopause specialists or sexual health specialists, I say reach out to them and see if you can meet with them because we really try and sometimes we fail to know the most up-to-date information on every single part of health. And so ask if there's somebody, if you're not getting enough relief from what your oncologist has said, ask if there's somebody that's a menopause specialist or a sexual health specialist in your area.
One thing that I will add on is that we did a retrospective review looking at sexual function after a physical activity intervention. And actually, those participants that were more physically active had better sexual function scores. And I think a lot of that goes to the whole body impact of physical activity. So even while you're waiting to get in to talk to your gynecologist or a sexual health specialist, a little bit of walking might actually get you going on the right track.
That's great. And Leslie in the chat mentions pelvic floor therapy always needs a mention in conversations surrounding sexual health as well. 100%. And just like there's physical therapy that's directed at other muscles in our body, there are dedicated vaginal and pelvic floor physical therapists that can be very, very valuable post-ovarian cancer diagnosis or post-hysterectomy surgery to help our patients. I'm glad. Thank you so much for mentioning that important point. And Sarah from OCRA, thanks for reminding us that there's a wonderful sexual health and intimacy session coming up at later today at 4 p.m. So I did want to also mention another comment in the chat that even, we do have to counsel patients that risk-reducing surgery is very, very effective, but it's not always 100%. And one of our survivors in the chat mentioned that she had undergone surgery at 47 for a high-risk gene mutation and then unfortunately developed peritoneal cancer after that. I hope you're doing well. And it's true that we need to counsel that 1 to 2% of our patients may be at risk for what's called peritoneal cancer or cancer of the lining of the abdomen with high-risk mutations. And that's very important that we counsel folks about. So I'd like to pivot a little bit to a couple other molecular testing questions, and then we'll go to, because we're getting a lot of great questions about surveillance, imaging, and treatment in the chat. So we'll dive into that. But would someone like to tackle, what is next generation sequencing or NGS testing, and what is an actionable mutation, and why do we like to see actionable mutations on these testing platforms?
I'm happy to start. This is the same thing that we were talking about with the when we keep saying somatic testing or tumor testing. We take the tumor and we send it to a company traditionally, or like we have our own internal, so some institutions do. But they take that tumor and the cells and they run genetics on it and compare it to what we consider a normal genetic profile in tissue that has no mutation. And then we know that some of those genes can promote cancer, or some of those mutations make cancer grow faster or make them spread more. And some of those we have targets for, like medications that say, okay, we know that this mutation is going to make this cancer grow very, very fast. So we're going to target that and slow down the growth of the cancer. So we get really excited when we see one of those, what we call targetable mutations. And that just means that we have a medication already available that we know should work in a certain percentage, of patients that have that mutation in their tumor. And that's why we get really excited about targetable mutations. Because then you're not getting chemo, you're getting something specific for your tumor instead of just a chemo that tries to kill all actively dividing cells, which obviously has more side effects than when we specifically target the tumor and the mutation. Anybody else jump in? That's a better way of explaining that.
I just think it's a really good example of how our cancer therapies are becoming more personalized. Like we're trying to become not just the oncologists that just throw everything at cancers and try to kill it all, but like really try to kill just the cancer cells. Because we hear from patients that, cancer therapies are really toxic and really challenging. And so we try to make our therapies as, as good as possible. Now, all of these therapies will still have side effects as any medication does, but we're really trying hard, kind of across the board to really make it more personalized.
Yeah, and that precision medicine or personalized oncology is really driving major change in the field. And we're seeing much longer survivals in our patients and patients living better because we're able to uniquely treat them in a way that we haven't before. So I love those two answers. And when do you all get your next generation sequencing testing done for your patients with either ovarian or endometrial cancers?
So we just decided as a group how we are going to do this. So it's great if everybody else answers. There's 12 of us in our practice, and so we all had different practice patterns. So for somebody with high-grade serous ovarian cancer, and obviously it's different for each type, but since that's the most common type of ovarian cancer, we typically get germline testing, and then we get myriad homologous recombination or whatever, just an HRD test to see if somebody is eligible for a PARP inhibitor. So we do limited testing up front. And then typically the first recurrence is when we do a big panel of testing where we look for kind of everything that we could potentially target. But we start with limited testing first, and then we move to our next stage. We do the testing on a bigger panel, and we either use the primary tumor, or if something's biopsyable, we'll get the fresh biopsy and send that. But I think everybody around the nation does it slightly differently. Like I used to send my whole molecular profile up front, and then we settled on this as a protocol for our institution.
Yeah, I agree with that. I think that we, as a group, generally send it at the time where we know that there will be a actionable mutation. So, for instance, Dr. Marjon mentioned homologous recombination deficiency. If they have an advanced, stage 2 through 4, then generally we will send it at that time because they would be technically eligible for a PARP inhibitor. In endometrial cancer, with exception of, research, we usually don't send it on the early stage patients right away, but if they were to recur, hopefully not, we would get it then. And then if they do not get it up front for the ovary cancer patients, like if they are stage 1, that's just getting chemotherapy, then we will send it on the back end if they did recur, which hopefully they wouldn't. So as long as there is a reason to be getting it, we usually get it then. And then obviously germline testing for everybody with epithelial ovarian cancer.
And so there's a lot of questions in the chat, as well as questions we received pre-session about CA-125 and other markers we use to diagnose or follow patients who have are receiving treatment for gynecologic cancer. Does anyone want to tackle that? Like, what is CA-125 and how reliable is it as a diagnostic biomarker in ovarian cancer? Let's start there.
Shannon, I feel like you should take this one.
Sure. So CA-125 is kind of a marker of inflammation within the peritoneal cavity. It can also be irritated if the pleural lining or even the lining of the heart is irritated as well. So it's very helpful and something that we can trend to get a sense of what's going on. In a single number, it's not necessarily as helpful. It can be elevated in anything that causes inflammation, such as endometriosis. I've also had patients whose CA-125 has spiked with COVID. And so it's something that we use as a marker and something that we can follow and help us guide when we're going to get imaging or if we need to get imaging sooner. But it's not like a strict yes and no when related to ovarian cancer.
And is anybody using it in endometrial cancer?
I do for my serous, if I've had serous or patients with especially advanced stage serous, at least up front to see if it's elevated. And then if it is, I'll follow it during treatment.
I do the same. I do it for serous patients or patients who have a mixed tumor and they have a serous component.
So you're saying like a uterine serous carcinoma or a carcinosarcoma or something like that. Okay. Okay. Yes, me as well. Dr. Marjon, looks like you wanted to say something.
I was just going to say, I think it's important to, like, the reason we say we use it in serous is while it does elevate with inflammation, so it's important not to take it as a, yes, you have a cancer just because it's elevated. Serous cancer cells actually produce it as well, which is why it's a good marker for high-grade serous or serous endometrial, and why we use it. But again, it's not perfect, so we like to trend it, and we don't typically treat on just an elevated CA-125. We typically need something on imaging before we start treatment.
Excellent. And there's several questions in the chat about HE4 as a biomarker. Are any of you using HE4 in your practices? It stands for human epididymis protein, and it's mostly been studied in trying to distinguish between benign and cancerous ovarian masses. I think there's one study looking at its sensitivity and specificity as a marker to, follow patients with ovarian cancer treatment. But I think most of us, at least in the academic centers, we're not consistently using those. We're certainly not including this biomarker in our clinical trials as one to follow when we're treating patients with ovarian or endometrial cancers. But certainly there's a lot of ongoing study about biomarkers and how to develop the best ways to detect cancer and follow patients to determine if the cancer comes back after treatment. But at this moment in time, the CA-125 is going to be your most reliable biomarker for fallopian tube, peritoneal, or ovarian carcinomas, especially those of the serous types, or if the tumor marker was elevated. I will say with the mucinous ovarian cancers, we sometimes follow a different marker called CEA, carcinoembryonic antigen, that's also more likely to be elevated in the cancers of the stomach and colon, which are also mucinous in origin. Anything else you all are doing from a serum or biomarker standpoint to follow patients with these malignancies?
Sometimes the CA-19-9, but it depends again on if it was elevated at the time of their diagnosis. And then there's obviously specific for rare ovarian cancers. There's other specific tumor markers that we get, but those are more rare. So
Exactly. Absolutely. And so those of you who may be represented patients who have been diagnosed with germ cell cancers or sex cord stromal cancers like granulosa cell tumors, and that may have different biomarkers we're following, such as inhibin B or LDH, and so those are going to be very specific to your tumor types. That's an excellent point.
And they do seem to be a little more specific. Like when an inhibin B goes up, it typically is more specific than a CA-125, but I would still get imaging before I start treatment.
Well, let's pivot to treatment now because there's a lot of questions about that. So one question from the chat was, what innovations in treatment or trials have you been most excited about in the last few years? And it's a great question, actually, because there's a lot we could talk for 4 hours about that probably. So we'll just try to summarize that. But for each of you, what do you think is one of the most exciting developments that you've seen in your lifetime as a GYN oncologist?
I truly think it's just the precision medicine. Going from this just blanket therapy of everyone gets the same thing, and then we kind of, as we go down the recurrence lines, hope that we're kind of guessing right. We're obviously using the evidence we have, but now knowing that a drug either is really likely or really unlikely to work with patients is, improving survival, but also delaying toxicity, which is really great to see.
Yeah, I think definitely for PARP inhibitors for ovary cancer and immunotherapy, especially for endometrial cancer, I think those are two really groundbreaking breakthroughs, for lack of a better word, that really did move the needle quite a bit, to the point where we may be, if we can, we will continue, but as we go on, we might be curing people that we thought were initially incurable. And so I think that's really, really exciting.
Excellent.
I agree with Dr. Toboni. I think coming down the pipeline, the most exciting things for me, we've made a lot of progress in antibody drug conjugates, and we're not really curing people with those, but we are decreasing side effects. And by, getting people more time without being on traditional chemotherapy. But along those lines, we're starting to do more things with bispecific antibodies where we can target multiple things, or like the immune system and the cancer. So stay tuned for that. But I think that's pretty exciting. They're making big headway in hematologic malignancies, and they're starting to slowly move into solid cancers. And so I'm pretty excited about seeing how those affect our treatment options.
Phenomenal. Exactly. Dr. Zamorano, anything else to add to that?
The only thing I want to add is, I think I can echo what everyone else said. I agree with, PARP inhibitors have really revolutionized the way that we look at and attack so many ovarian cancers, and kind of expanding to other tumor types. But also now, as we get into precision medicine, thinking about how we can pare down our treatments. So this is again about, addressing the toxicities that these treatments have, and then also thinking about the duration of therapy, especially with some of our maintenance therapies. We've kind of set this timeline based on the trials, but now thinking more critically about how long do we actually need it to be equally as effective. And so to me, the most exciting thing is just making our therapies work a little bit better.
I do see a lot of talk about that, like how long do we keep things on? And Dr. Fader, I actually have a patient who's been on Herceptin for a while now. It's from Dr. Fader's trial with a serous endometrial cancer with no recurrence. She's in her 80s. She's like, when can I stop this? And we don't have a good answer to that. So at some point, you do have to have these really difficult conversations with your physician and just make a decision about when to stop it. But then we are getting exciting trials, like with the PARP inhibitors. Like, can we just do a year and not make you have the side effects for 2 years? So we're starting to think about that in a more
Absolutely
strategic way.
And I think we're going to go to that in just one moment. So hold that thought, Dr. Marjon. I wanted to introduce Dr. Katherine Kurnit, who is assistant professor at the University of Chicago and just a wonderful GYN oncologist and rare tumor scholar, Bridges scholar. Did you want to say hello, Dr.
Yes,
Kurnit?
thank you, Dr. Fader. Thanks to everyone for having me. Sorry to be late. Yeah, I'm excited to be here. I'm very interested to kind of hear from my colleagues and hear from you all about the things that are most important. But some of my interests are specifically in developmental therapeutics and kind of early phase clinical trials, and trying to find new ways that we can treat all of these types of cancers, hopefully more effectively, but also while maintaining good quality of life for the long term. So I'll just echo for what everyone has already said. I think, like, philosophically, I'm just so excited that over the last 10, 15 years, we've just seen more options, we've moved away from just saying cytotoxic or traditional chemotherapy is the only option that we have. And now we have things like immunotherapy and targeted therapy and antibody drug conjugates. And I think that that's really phenomenal. And I'm very excited for all of the many researchers who are doing that early phase, like the lab work, to help us find these new drugs. But I also have to say that I'm very excited about all the, I'm sure we've talked about this, but risk reducing things, all of the things that we can do before the cancers actually start. Because I think when we think about how can we really move the needle, I think it's preventing the cancer in the first place. So I look forward to the day that we don't have to actually treat ovarian cancer at all.
Yeah, when we're all out of a job, right? And can
Exactly.
study some other important
Right.
question. I totally agree with
exactly.
you. And I was going to round out this. The question was, what are you most excited about in terms of advancements in the field? And I would say, I agree with everything that's been said, but the advances in prevention and early detection are phenomenal now. I have to give a plug for the HPV vaccine, for all of you out there, for your families, for your friends, for yourselves. One of the single greatest cancer prevention inventions of all time. I don't have any stock in Merck, but this is one of the safest and most effective vaccines ever created. And it can literally eradicate cervical cancer if we have enough of the population vaccinated across the world. And then the amazing advances we've already talked about in self-injectomy and risk reduction are going to be a game changer in reducing ovarian and fallopian tube cancer rates. And at our center, one of the areas I focus on is early detection in endometrial cancer, where we also don't have a screening test, just like for ovarian cancer. We're working on a tool called the Pap-seq, which is an opportunity to use genetic molecular testing with a pap smear to detect the gene signatures of patients with precancer or cancer, so that we can potentially treat patients before they develop invasive disease. And so many of us across the country are working on all these efforts, and it's an exciting time. Hopefully in the next 10 years, we'll be able to bring something to market with regards to that. But so yes, so ctDNA, I think, is another sort of exciting opportunity to monitor cancer. Does anyone, Dr. Zamorano, do you want to talk about how you're what is ctDNA, and how are we utilizing this in practice across the country?
Yeah, sure. I've been noticing all of these questions. There's so many questions on ctDNA and Signatera. Signatera is the name of the company. And so we use those words pretty interchangeably because Signatera or Natera is kind of the most prolifically used. But essentially ctDNA are kind of small tumor molecules, fragments in a patient's bloodstream that can be then analyzed to look for the presence of tumor. And I know others can jump in because they have a lot of experience following ctDNA as well. I would just say for this that this is a really, really exciting way or exciting movement in cancer detection. But we in GYN cancers we still need more data to know how to use this. So we are all in agreement that this is like really exciting and we love where this is going. But if someone comes with an elevated ctDNA and a history of ovarian cancer, we don't actually know if the right thing, and let's say their CT is negative, like their CT scan is negative, we don't actually know if it's a good idea to go ahead and start treatment or if we should wait till we see something on the CT scan. We still need this information. There are studies looking into this exact question. And so I think in the next couple of years, hopefully we'll have a lot more data on this. There's also studies using ctDNA to help us determine which patients maybe should be on maintenance therapy after their initial chemotherapy or at any point kind of in their treatment journey. And so we're looking at this in a bunch of different ways, and we all agree that this is super exciting. We just are a little bit cautious because we want to treat all of the ovarian cancers, all of the cancers, but we don't want to over-treat. We don't want to cause unnecessary toxicity because all of these therapies do have real toxicities. And so we don't want to injure patients, of course. And so we're all very excited, but we're a little cautious.
Yeah, they're being definitely included in our clinical trials, and we're studying them very robustly now in terms of the best applicability. Dr. Toboni, did I interrupt you? Did you want to say something?
No, I was just going to echo what Dr. Zamorano said. The cat's a little bit out of the bag before we kind of validated the test. It is very exciting, and it seems to be, at least with retrospective data, very prognostic, meaning that it can predict recurrence before we do things like CT scans and stuff like that. But up to this point, we have a prospective trial going on here, looking at it in early endometrial cancer. and have published in ovarian cancer in people on PARP inhibitors as well as early stage endometrial cancer. And while it is very exciting, I'm always very careful to tell everybody that what is out there right now is retrospective in nature, which doesn't mean that it's not valid. It just means that we need to do much more work in order to make sure that we're using it in the right way. And so we're really trying to work hard to do that. As Dr. Fader said, we're trying to include it in all of our clinical trials as much as possible, because ultimately that is going to be the reason to, or that's going to be the best evidence to kind of make sure that it's predictive of the treatment responding as well as predicting recurrence from happening. Right now, I believe that the indication, at least CMS wise through Medicaid, is just if you're on immunotherapy. I don't know if it's happening right now for PARP inhibitors, but I have been able to get it covered for that. But ultimately, when I have a positive ctDNA, I don't make decisions based on that. Sometimes I'll get a scan earlier if I wasn't planning to, just to make sure. But it's important that we use the tried and true methods first and foremost before we start acting on this individually in a silo. So I agree with Dr. Zamorano.
Dr. Zamorano, Dr. Toboni, those were wonderful answers. And I think Susanna in the chat made a great point. You know, just like we don't necessarily treat with an elevated CA125 without clinical confirmation of, you know, disease that could be harmful if not treated, that, you know, we're sort of taking that cautious approach here. Although we may find that ctDNA ends up being more sensitive, you know, indicator of active disease than CA125. We don't know yet. Those are one of the great questions that are being answered. How much more time do we have in this?
About 5 minutes left.
5 minutes?
So, and then we'll have a short break before returning for part 2.
Wonderful. At part 2, I think we're going to focus a lot more on treatment questions and side effect questions. We've really tried to cover a lot of ground here with testing and genetic and somatic testing, what's coming down the pike in terms of interesting innovations in the field, menopause and sexual health, but we will have so much more to cover. But since we're on the ctDNA topic right now, and there's also a lot of questions about maintenance therapy in ovarian cancer you know, that coming through the chats. Let's talk a little bit about maintenance to finish out this 5 minutes. What is maintenance chemotherapy? And are you all using, are you less likely to continue maintenance treatment if a CA125 is negative or a Signatera test is negative? Does anybody want to tackle that? Dr. Kurnit, do you want to start?
Sure, I'll jump in. Sure. It's a good question. It's a tough question. I think about maintenance therapy as a way to, truly maintain what we're doing. So I don't think of it as quite as ideally as strong as the chemotherapy, hopefully both in terms of side effects, but in terms of like anti-cancer properties, although that's not always true. But it's a way to kind of bridge that gap between doing full dose treatment, whatever that is, and doing surveillance or kind of no treatment, kind of keeping whatever cancer that might be there at bay and kind of at a low level or, not detectable. I think that I try to be at least as true as I can be to the studies that were done. So in a study for olaparib, for example, that they used the PARP inhibitor for 2 years, I try to do that with my patients. I try to follow what they actually did in these studies where we see the results that we're excited by. And sometimes that's not possible, or sometimes the side effects are too much, or, there's all sorts of reasons that changes. But I do try to, as a starting point, aim for what we did there. But I think that there are instances that we don't quite know how long the right treatment is, the right length of time for maintenance therapies. Is it indefinite? Is there a stopping point? Does it matter if you stop it in terms of what happens later? And so I think that's where CA125, if the CA125 has been very low for a long time, or if the Signatera is negative, then I might feel more comfortable having that discussion about maybe it's time that we can de-escalate this a little bit and try to improve quality of life, depending on the symptoms that we're having. But I'm interested in other people's practice patterns also.
I just wanted to jump in and say that, because I see some chatter, maintenance is different, whether it's your first diagnosis or if it comes later. So is treatment. So if it's your first diagnosis, we often have limits on our maintenance therapies. Whereas if it's a recurrence, we often say we treat until progression or inability to tolerate. And so I think that's where some of the confusion comes in on timing of maintenance therapies, depending on what it is.
Yes, for sure. Although I will say that in some of the some of the cancers where we haven't studied the optimal duration, like you mentioned, trastuzumab or Herceptin earlier, and even using things like aromatase inhibitors like letrozole and low-grade serous carcinoma, we don't know the optimal duration of time to stay on a maintenance therapy. This is something that's an active area of investigation now. And so I think in terms of those questions in the chat, talking to your providers about what's best for you and really what your goals are with your treatment and care, does your side effect profile look like on these maintenance treatments is a really important factor in how long one continues. But also with PARP inhibitors, right, there can be harm, right, if we continue them too long. Can anybody speak to that a little bit?
I don't know who wants to take it. So, I mean, there's just the general side effects of PARP inhibitors, which are not too dissimilar from cytotoxic chemotherapy in some patients. It is an oral-based chemotherapy, but when we think about potentially duration of use, the biggest thing that we worry about is myelodysplastic syndrome, and so there's concerns with kind of dysregulation, dysfunction of the bone marrow, with potentially related to duration of use. But so that's something to consider. I don't know if other people want to weigh in as well.
I think that's something that's really important to discuss and consider, because it's not just because we're continuing it for a long time and there's not obvious side effects. Kind of once the myelodysplastic syndrome comes about, it's not just like a snap your fingers, stop the pill, and everything goes back to normal. I think it's also why we're doing studies, pragmatic studies, to look at the differences in stopping maybe Olaparib after 1 year versus 2 years. And so I think we're being really thoughtful as a group of researchers and GYN oncologists about kind of trying to get some more hard data to help us figure out when we should be stopping these therapies for our patients.
I think the other thing about the MDS and the AML that comes from drugs is that it's not the same. Like if you had a family member with MDS and they kind of just follow it, it's much more aggressive when it's drug induced. And so that's why we're so thoughtful about stopping it and not continuing PARP inhibitors, because there is a real risk of harm that's very difficult to treat.